Okay, everyone. Welcome to class number 6 of Advanced Quantitative Research Design. Um, this week, I wanted to, the topic this week is primarily going to be about psychological test development. Now, I realize that you both are also in the psychological testing and assessment method. And to be honest, when I set up the each week of the course, I wasn't, of course, didn't know that the students in the uh, one course would also both all be in the other course. So it was a little difficult this week. I wanted to um, develop talk about this in a way that didn't overlap with what we were covering in the testing and assessment course. Um, Now, one thing I can tell you is in the readings for this week, um, I had mentioned that there were going to be articles. Um, as I said, when I developed the course, I didn't know that the students in one course were all be in the other, and the articles I was going to use were going to be the same ones in both courses that talked about validity and reliability. So right now, I'm not planning to have additional articles, but I would ask that you go back to the reliability and validity articles that I had you read for the testing course, so that to really sort of familiarize yourself with the concept of um, reliability and validity. But I thought as a way of presenting useful material and so that we could lean more to the quantitative part of test development rather than the practical application part of the testing development. I thought I would spend this course talking about the development of a completely different psychological test than the one we've been talking about, the testing and development course. And so I'm going to talk about the Beck Depression Inventory. One of the reasons I like talking about the Beck Depression Inventory when it comes to developing tests is that it is a much more, it's very, very effective and very useful, but it is much more limited than the MMPI. When we talk about the development of the MMPI in the other course, we will talk at length about a very detailed, complex process by which the test was developed because it has several hundreds of questions, um, many different scales, all meant to test for different things. There's quite a bit of overlap. Um, and um, as I said, there's quite a bit of overlap. There's a lot of discussion about how the scales interact with each other. When we talk about the MMPI, we will, um, or the MMPI 2, excuse me, we will be talking about, uh, we will be talking about how interpretations are made based on the result of multiple scales. So there was a lot of complexity in terms of how the interpretation is made. Um, the Beck Depression Inventory is an excellent example of what is on the other side of psychological tests. And in fact, when we talk about objective tests in the other course, I may be bringing up the Beck Depression Inventory as well because it is an excellent um, example of a limited use objective psychological test. But the reason I like to talk about it here is because it's of limited use. Um, it talking about its development and the specifics of how it was developed is a lot more straightforward. Even discussing another important aspect of it that's similar to an aspect of the MMPI, in that the Beck depression inventory is in its second edition. So the Beck depression inventory that you will use these days in a clinical setting is called the Beck depression inventory 2, or the BDI 2, because it's in its second edition, similar to the way that the MMPI that we use and that we talk about in the testing course is the MMPI 2. Excuse me, 1 second. Okay, so the Beck depression inventory is in its second edition, and the MMPI is in its second edition. So what that means is, at one point, there was um, uh, another edition of the Beck depression inventory, and it was changed, um, that it was changed based on some updating of the understanding of depression, what symptoms might distinguish depression, and also changed because of some of the wording. In fact, it's interesting that the MMPI2 and the Beck depression inventory were both changed, um, in large part because there was concern about the wording maybe being outdated. The original Beck depression inventory, um, it was developed in 1961, and then the updated version of the Beck depression inventory, the Beck depression, the BDI 2 came around in 1996. Okay. Um, so, and if you hang on 1 second here, I will um, hang on. Here's the Beck depression inventory 2. You should see it on your screen right now. Uh, Now, to be honest, I'm not sure how I got this. What I mean is, I found this online. The Beck depression inventory 2 is copyrighted. Um, but I believe this was put out before it was copyrighted. I found this online. So it just it it gives you a sense of well, it shows you what the questions are here, but I believe now you have to buy it um, by the Psychological Corporation, unless you can find it online like I did. Okay, so I bring this up, like I said, this is, we'll talk more about the practical application of it if we get to it in the psychological testing course. But I did want you to get a sense that what I wanted to talk about is the more formal quantitative research approach to test development. Um, so notice what you have here. In the end, uh, psychological test development comes down to starting off with a group of items that you believe will help distinguish one group from another. In a single use, in a limited use psychological test, um, that will be how you develop a test, is you will identify what um, factors you think contribute. In this case, going back to the development of the Beck depression inventory, how the Beck depression inventory was originally developed was Beck is the founder of cognitive therapy and started cognitive therapy in the treatment of depression. And the theory that Beck developed was a theory of depression reflected in negative thinking. So what Beck did when identifying the um, when identifying the items that needed to go into the Beck depression inventory was to gather together what he and his colleagues at the Cognitive Behavior Institute um, uh, thought were the main ones that were reflected in the negative thinking that they were seeing in depressed patients. So, in the end, how this all came together was they got together their listing of what items they thought contributed to individuals' negative thinking when they were suffering depression. So they found a large group of depressed individuals and compared them to a group of non depressed individuals and identified the sort of negative statements that individuals with depression made more often about themselves and about their lives than individuals did who were not depressed. Okay. Um, and then so it was based on clinical observations of attitudes and and expressed symptoms that were occurring frequently in depressed psychiatric patients and those that were um, found infrequently in non-depressed psychiatric patients. So it really was uh, a comparison of individuals who were suffering depression compared to individuals who were um, not suffering depression in a clinical setting. Now, what's particularly notice when there was this development of this test, notice how this relates to objective definition that we talked about in here. How did they determine if the person was depressed? And it was based on clinical diagnoses. Each of these individuals were in a psychiatric facility, and the depressed individuals were the individuals in that facility who were there for depressive diagnoses. And they were compared to non depressed psychiatric um, uh, patients. And from that, there were 21 items that came up, and each of those items are ranked from 0 to 3 for severity. Um, so, um, and you see some of the items there. Sadness. I do not feel sad. I feel sad much of the time. I am sad all the time. I am so sad or unhappy that I can't stand it. Um, and then just some other ones I'll get on. Worthlessness is number 14. Loss of energy. Um, Irritability, changes in appetite. So you see here as you go down through the 21 items, uh, the different symptoms that are associated with depression. And if you look at it, it kind of looks like if you had you could kind of picture how this developed. You had a bunch of experts who started off observing depressed and non-depressed psychiatric patients and looked at what were the individuals with depression saying more often or complaining about more often compared to the individuals who did not have depression. And you get a sense if you look at all 21 items that they're pretty much what you would expect to be the major factors distinguishing the two groups. You know, you could almost look here and see each of the items relating to a specific symptom of depression that you most commonly hear about. Feelings of punishment, feelings of guilt. And it is useful to keep in mind that this came primarily from Beck, who was the founder of cognitive therapy, because the symptoms that are reflected here also seem to be most common with the type of negative thinking that is often associated with depression. Okay, so these individuals are all put together, and and a test is a set of items is developed. So then the question then becomes, based on that, how do they distinguish which items should be included? Okay. What I'm now going to do is um, the stuff so far that I've talked about is the Beck depression inventory. Um, Now, what I want to go to is talk. I'm now going to switch to the Beck depression inventory too, as I talk about some of the psychometric principles. So, and I'm summarizing thing in a more basic uh, level because there have been hundreds, if not thousands, of studies of the Beck depression inventory too. So, saying, for instance, how cutoff scores, how validity was determined, how reliability is determined, is a little complex because it's actually come from multitudes of different studies and that sort of thing. But I'm going to give you uh, some terminology that will help with understanding test development. So let's start first with, how do you determine the cutoff? How do you determine what um, what score is used? Because in the end, that's really the basis of where this course carries over to the next course. Because you could say, well, you got this Beck depression inventory, and we uh, validity and reliability are going to determine whether we have a solid test. Validity, of course, as you know from before, validity means, does the test measure what we say it's going to measure? Reliability means, is there consistency in its use? Those are going to come, and we're going to talk about those in a minute as far as the statistics that are used for that. But one other question that's going to come up for a clinical determination is, when we've determined that this is a valid and reliable test, uh, what what scores do we use to distinguish between whether the person has the condition we're measuring or not? So in this case, the question comes up: what's the cutoff score for determining um, depression versus non-depression? Now, this is actually a step that would come later after you develop reliability and validity. I just happen to have it first here because I had the material in front of me. So we'll start here. So um, once the BDI-2 was developed and the validity and reliability were um, confirmed or supported, what came up next was, how do you determine the cutoff score for distinguishing between someone being depressed and non-depressed? Which, by the way, with the BDI-2, there were multiple sets of questions regarding cutoff scores. I'm just going to focus on the development of the cutoff score for determining depressed versus non-depressed. The scale is also used for distinguishing mild, moderate, and severe depression, but I'm just going to focus on, how do you uh, how do you determine if the individual has depression compared to the person not having depression? And what they did was, um, they gathered a group of people. Now, this is all the popular, or the sample that you use for developing a test is always different from the sample that you use, or should be different than the sample you use for determining the norms later on. Or at the very least, you may use one sample to develop the test and also base the initial norms, the initial cutoff scores off of that test. But then you should continue studying it on different populations. And here is the process for developing the cutoff scores. Um, um, Once the validity and reliability had been formally determined, and we'll talk about those results in a minute. Um, they took the test and gave it to a sample of individuals. Again, these were individuals in a psychiatric facility. And the question was, what score best distinguishes individuals with depression from those individuals who don't have depression? And the statistics that are used, and this is the important part, the statistic that was used for determining uh, the cutoff score was, it is called Yoden's, Youden apostrophe S index, Yoden's index. And um, Yoden's index identifies uh, the rate of sensitivity and specificity. Um, and what that means is, um, and I'm sorry, I wanted to just, I took a pause there because I wanted to make sure I did this right, because the sensitivity and specificity are the opposite of each other. Sensitivity is the ability of a test to correctly identify patients who have a condition. So, for a psychological test like the BDI, sensitivity would be the ability of the test to correctly identify those individuals who have depression. Specificity is the ability of the test to correctly identify people who do not have the condition. So, in the case of the BDI, it is the ability of the test to detect those individuals who do not have depression. Sensitivity identifies individuals who do have depression. Specificity identifies those individuals who do not have depression. And the statistic that you use for determining um, specificity and sensitivity is Yoden's, Youdens index. So, and just to get down to the numbers there, um, the cutoff score was found to be 23. So what that meant was that if on this 21 item index where you have 0 to 3 on each item, so you essentially have a possible score of, the highest score you could get is 63. A score of 23 or more, when that was used, the sensitivity of it was 0.88 and the specificity was 0.92. So that meant um, when you used uh, the cutoff score of plus or minus um, 23, you had it was 88%. Um, excuse me, it was 88% that um, showed, yeah, 88% of the time, individuals who did have depression were identified, and 92% of the time, individuals who did not have depression were correctly identified. So that was a reflection of the ability of the test to correctly identify um, individuals with depression and individuals without depression. And what Yoden's index shows you is it maximizes both. So it finds for you that cutoff score that is going to balance your best outcome for sensitivity and your best outcome for specificity. And that is um, the what you're looking for is you want a cutoff score that is best going to um, you don't want to, because if you have a test that will correctly identify um, you know, people with depression, uh, you know, if you were only worried about correctly making sure you had everybody with depression, but you weren't that concerned about whether people without depression were correctly identified, you could just set a cutoff score of 3. So anybody with a um, anybody with a score of um, 3 or above is going to be listed as very likely having depression. Well, you'd catch everybody, you'd probably catch everybody who has depression, but you'd also incorrectly identify probably the majority of people who don't have depression. So you need a test. That's why you have Yoden's index, because it's a it's a complex form of correlational analysis whose sole purpose is to balance out correctly identifying those who have the condition and correctly identifying those individuals who do not have the condition. Notice how, one's 0.88, meaning 88% correctly identified as depressed, and 92% correctly identified as not depressed. One thing, by the way, I did want you, and this is more an understanding of depression, but it's also important for understanding the limits of every test, and specifically identifying a limit with the BDI is, notice how it's developed. And when I say BDI from here on in, I mean the BDI 2. Um, but notice how its cutoff, its development is psychiatric patients and correctly identifying those with depression from those without depression, but they're all psychiatric patients. The original BDI norms and the original BDI 2 norms were not based on people with depression and those who had no psychiatric illness whatsoever. The main concern was um, identifying those individuals with depression compared to those individuals who had something else. Um, Now, it's still useful. I mean, it certainly is useful for um, screening out individuals who have depression and those who don't have depression. The reason the BDI was developed this way, and I'm just bringing this up because you may have noticed it, is because the assumption was that the BDI would be used in clinical facilities or would be used in some sort of place where the people coming in were already identifying a problem. Um, so it's not a test that is typically used in like um, an employment setting where you may have people who have no problems whatsoever. It was meant as a clinical instrument. So the primary question they wanted to make sure they could answer is, could we identify depression? And it was thought that the best way to do that was to make sure you could identify depression and screen it out compared to other conditions that people might present: anxiety, anger management, uh, attention problems, that sort of thing. So it is considered to be useful still as a cutoff for distinguishing people from depressed from people who have no problems, but it was primarily developed to distinguish it from depression compared to people who didn't have depression but still do have something else because they were all in psychiatric treatment. Okay, so that's how Yoden's index is how the cutoff scores for the Beck depression inventory are initially developed. So now let's move on to talking more about the other aspects of the Beck depression inventory too. Okay, so so we got through the cutoff there. Okay, let's go through validity and reliability. And again, what I want to focus on here is the formal statistics that are used for uh, the validity and reliability measures. So what I'm sort of focusing on here a little bit differently than what we've addressed in the psychological testing course would be the actual statistics and the testing procedure that is used to define validity and reliability when it comes to test development. So let's talk about the different sorts of I'm sorry, validity first. Um, so um, okay, so let's start with content reliability. And what happened with content reliability is that different types of clinical ratings of uh, depression uh, were used to determine if so uh, different rating scales uh, for depression, clinical ratings of depression. So in this case, the validity was to sort of determine if the items that were used in the BDI to identify depression were similar to what was being addressed when clinicians were rating depression. So basically, what they would find out is what they would have a structured procedure by which clinicians were rating people who were being treated for depression. And then they were seeing if those rating scales correlated with the severity of scores on the BDI. So the sort of theory here is that the content of what the clinicians were using for their rating, they were seeing whether those results were correlating with the outcome in terms of severity on the BDI too. And what they found was correlations of 0.72 when the rating was used for individuals with depression, um, and zero point 0.6 when the rating was used for other conditions. So the idea being that you would expect that the clinical ratings uh, for depression would be higher as the BDI scores got higher. And then when they were using non depressed individuals, the correlation was in the opposite direction. So that's considered to be significant. So, and one thing I want you to keep in mind that's important to notice is the statistic. I talked about the Yeoman's Index for specificity and sensitivity. But other than that, and some other tests, for the most part, the statistic that is used the most often when developing tests and determining reliability and validity is the Pearson correlation coefficient, which is the main measure of correlation. So that's very important to keep in mind. So most of the time, the determination of validity and reliability is correlation. Okay, so when they were doing content validity and they were determining if the BDI matched up with the wording that clinicians were using when rating individuals with depression, um, they found a significant correlation. Construct validity um, was the degree to which um, specific symptoms of depression were listed out, and just sort of the check of the number of symptoms um, uh, were, and this would be the DSM-5. Well, at the time the BDI was developed, it was the DSM-4. Now it'd be the DSM-5 with the more recent research. But so content validity had to do with the specific steps um, clinicians were using to rate psychiatric patients and how that matched up with scores on the BDI. Construct validity had to do with the specific symptoms. So it was a checklist of the number of symptoms. And that was seen as having a very high correlation of 0.92 for individuals with depression. So, like the number of specific, basically, this was the degree to which scores on the BDI correlated with the specific criteria that was laid out in the DSM-4 for depressive diagnoses. Um, and then concurrent validity, that's the validity that matches up um, how well the BDI um, correlates with other measures of depression, uh, and specifically with the MMPI-2, the correlation was 0.77. Uh, and with the Hamilton Depression Rating Scale, it was 0.71. So um, those are uh, two, again, significant correlations with two other instruments of depression. So going back, content validity had to do with whether the content of what was included um, uh, in the instrument matched up with what clinicians were using in their own professional capacity to determine if someone was depressed or not. Because keep in mind too that the BDI and this the BDI is what's called a screening instrument. It determines whether further evaluation for depression is needed. It doesn't replace the clinical interview. It's just seen as sort of a faster, more convenient way of at least distinguishing whether a person might have depression, uh, so that every so you can sort of have um, a starting place. You sort of have an idea of what this person might have before you delve into the clinical work. Uh, but when they went to individuals, the clinicians, and determined what steps they used um, for for assessing depression, that matched up. That was what was used for content validity. So, and that matched up. Like I said, uh, that had a correlation of 0.72. Content validity had to do with the degree to which the test matched up with um, specific symptoms. So, specifically, the symptoms in the DSM for depressive diagnoses, and that was construct validity, and that was 0.92, which was the highest, which was very high. And if you look at it, um, you can kind of see it because the questions when I showed you the BDI two, the questions were kind of like just all the cognitive symptoms that are associated with depression. And then the degree to which it matched up with other measures of depression, specifically MMPI2 and the Hamilton Depression Inventory, that rating there was in the zero point 0.7 range. And then when we get to reliability, there are two specific types of reliability that were used for the BDI. One was internal consistency. And internal consistency is that split half reliability that I talked about, where the idea is that um, the scores, if you have a test that's supposed to measure um, sort of the same construct without, the BDI does not have separate scales. It's not measuring different things. It's measuring depression. Well, when you have sort of a um, unified instrument like that, um, if you have reliability, if you have consistency in the results that the person has, then what they get in one half of the test should match up what they get with the other one. And so that split half, where a split half reliability is where you take one half of the test and correlated with the other half. That split half correlation was 0.91, which is a pretty high correlation. So that's really good. And then the other one is the test retest reliability. And that is the degree to which, if you give the person the test at one point, how much does it match up with the score they get at another point? And if there is a difference of only a limited amount of time between one administration and another, and it wouldn't be enough time for the problem to disappear, then the correlation should be pretty high. And in this case, it was the test retest reliability was 0.93 at 1 week. And what that meant is a group of individuals took the BDI at one point and then a week later took it again. And the validity of those scores was 0.93, which is again very high. Um, and 1 week was not seen as enough time that the depression would have gone away on its own. So these were individuals who within that week didn't have treatment. So it was expected that the score should be pretty similar if the person had depression and not just really a down mood related to a specific incident. Because even an adjustment disorder is expected to last up to 6 months. So, and again, and I apologize, I'm not sure. I know you all had this material in the testing class, but just to remind you, reliability is the degree to which there is consistency. So a person gets a score on the test at one point, it is supposed to be similar to the score that they get at another point. And the way that is specifically tested here is internal consistency, the split half, correlating one half with the other half. And that was in the 0.91 range, and the other was test retest, give it one point a week later, give it again. That was in the 0.93 range. And then validity is the degree to which the test actually measures what you say it's going to measure. And that was the content validity, um, construct validity, concurrent validity, and criterion validity that I talked about a little bit ago. Um, and then there's another issue is using the test with different populations and different languages, different cultures, uh, uh, different um, groups of individuals to make sure that it works in different places and with um, people of different backgrounds. One example of how that was done is the BDI was tested specifically in Brazil on a group. The reason why this study stood out is because of the large number. It was done with a group of uh, over 1,500 people, and it was found that um, uh, that it did very well as far as discriminating. To, so the cutoff scores worked very well in that population as well. Um, and then there was also development of individuals on the BDI for individuals who have different medical problems. A study of 800 people who had coronary artery disease, um, distinguishing people from depression from those who did not. A lot of times, it's interesting. You want to use it in different cultures and in different language to make sure it can be used in different populations. A lot of times, tests of depression and tests of anxiety are also studied specifically for individuals with different health problems because some of the symptoms, say, if you think about it, some of the symptoms of depression, low energy, low motivation, slowness to respond, those can all be characteristic of different medical problems as well. The Beck Anxiety Inventory, which is a different instrument, but also initially developed by Beck, actually gets a lot of criticism because there's a lot of physiological symptoms in there. So a lot of the symptoms of anxiety that are outlined there could be consistent with different medical problems. Okay, so that's the specific statistical approach to test development as it was applied to the Beck Depression Inventory. I'm going to stop there as I know you all have a lot of work, well, not only for this class, but for the other class. And I will see you all on Thursday.